Okay, hello everyone. Welcome to a new episode. This is another Spotlight feature, and I'm so pleased to have with me a very special guest, Dr. Freeman Chakara. Thank you so much for joining me today. I really appreciate it.
It's a pleasure. Thanks for the opportunity.
Of course. So this is really the first time that you and I have been able to speak. I know we've been part of that membership for some time, but I really wanted to talk to you more about just your journey because it's very important to me that we really put a spotlight on our members and hear about the work they're doing, the work they have done, and what kind of brought them to this field. And so I know that you are a neuropsychologist by profession, and I know that took a lot of years to get there, but let us kind of rewind the clock a little bit. And I always like to ask people, what was your childhood like? Let's start with where you were born and where you grew up.
Thank you. I was born in Zimbabwe, Southern Africa. It was then Rhodesia, which was a British colony. And we gained independence in 1980. And so I grew up in a village. Frankly, I was, born in a mud hut, no running water, no electric. Did not have. I don't think that I don't recall seeing any motorized transportation until about perhaps 5 years of age. But at about 7, started attending a mission school in my village, which, as you may know, back then, British educational systems were pretty rigorous. So in first grade through sixth grade, I attended that mission school in our village. So you go to school, you come back, you herd your cattle and your goats, and you live life in community. And then when Civil War came to our village, I moved to the capital, lived with my uncle. Then I attended public schools in our little town outside the city of Harare, and did high school there, and then worked a year or two in a bank before moving to Calgary, Canada.
Oh, okay.
For a couple of
I
years,
have
and then
family there. That's nice.
oh yeah. So lived there for a couple of years, and then did undergrad in Georgia, small college, Chakara Falls College. In '94, started my doctoral program at Widener University, which is in Philadelphia, just outside the city. So it was either Temple or Widener. Widener had it's in my view a slightly stronger clinical emphasis, and they had both school psychology and neuropsychology areas in which I was interested, and I really had an interest in clinical aspects, with probably research and maybe teaching as sort of close secondaries, but more clinical interests. I was commuting, so we live in Lancaster now. So I was commuting from Lancaster to Philadelphia for about 5 years.
Oh, wow.
I remember we had neuroanatomy classes at Cooper Hospital at early in the morning, like, so we had to be in the morgue at 8 o'clock in the morning, and sometimes I'm commuting from my house at 4 in the morning just so I could make my labs and so forth. So yeah. So growing up in Zimbabwe and living in North America through Canada clearly had its own transitions, as you can imagine. Yeah.
Thank you for sharing that. I'm curious with those transitions, what because that's really a lot to have to adapt to. So, what do you think now, currently, you've really taken away from those lessons of having to move and adapt to new countries and new cultures? What do you think how has that sort of impressed upon you in your current state?
Well, in retrospect, I am frankly impressed with how resourceful, how resilient folks in my village were and
Mhm.
are today. There are soft virtues such as patience and temperance that I on occasion catch myself, running short on, whether it's, waiting for, neural images to be sent to me to prepare my report. There are sociocultural virtues of kindness and consideration for other that now, we introduce to our profession vis-a-vis, DEI conversation that have always been part of the ethos of the simpler community in which I was raised. So, my guess is there are also some things that I've had to learn. So overall, I think moving into different spaces in different cultures has, I hope, cultivated attributes of flexibility in me, compassion, understanding, and a lot of sort of introspective self-awareness about, myself in the space in which I have to function, so to speak.
Right. In your traveling or your relocating, what for you was the hardest thing to adapt, or what did you find to be the most difficult obstacle about trying to get settled into a new culture, a new country, and adapt to maybe the custom? What was something that maybe stuck out for you during that time?
I would tell you, unfortunately, I had an incident when I was in Georgia as a freshman. Now you have to appreciate that I grew up largely in a village in Zimbabwe, and so here I am. I'm a college freshman in Northeast Georgia, and I'm driving with a friend of mine. I'm a passenger in his vehicle, and we're driving down this country road, and I see a smallish group of people wearing what appear to me to be white sheets covering their visages. So I don't know, at least at that time, I don't know that this is apparently a hate group. And so I say to my friend, can you stop? It appears there are people passing out some educational materials. Maybe they are out for a good cause. At which point my friend stepped on the accelerator and said, you clearly don't want to stop here. So we get to school, and I start to sort of explore and try to understand what was going on. So clearly, every community, I think, has to wrestle with some kind of tribalism, or however you label the tribe. Okay. However, adapting, well, I don't know about adapting, but trying to understand, trying to make sense of levels of hate that are driven primarily on superficial aspects towards other folks were a little bit tricky for me to sort of wrap my head around, especially earlier on, just because you grow up in a village, and your neighbors know you know their neighbors. There is the novelty of the bus came from the city today, and they discovered this is happening in England or whatever, and so that's about the scope of the news. And then to find myself in sort of multi-layered, complex situations in a small, remote town in Northeast Georgia in southern US, and so having to work through sort of historical, cultural aspects that were very true for folks that look like me, whose experiences were historically quite different than mine, was in itself a loaded challenge. So,
Of course.
yeah.
That's a really interesting point, because one thing I'm curious about, and I'm wondering if you can give me your perspective, is oftentimes when Africans are coming to the US, they may not be aware of the complexities of these hate groups like the KKK and racism and just the racial tensions that have arisen in the country. Do you feel like, in retrospect, you would have benefited from someone before you moved to this part of Georgia, could have taken you aside and letting you know about these things? Like, hey, there's this group that is pretty predominant in this area called the KKK. This is what they believe. Do you feel like going forward, you would want to pass along that kind of insight to someone who is newly arriving, like yourself, to the U.S. and may not understand the complexities of hate groups and racism in America? Do you feel like that's a beneficial thing to pass on to Africans who are coming to the U.S.?
In retrospect, yes. And that conversation, I think, should have happened with my advisor when I was on the continent versus just that happening upon getting to campus, because there are multiple services, multiple processes that you have to work through. Where's my dorm and where's the library? And so you have sort of those immediate needs that you have to think about. And so some of those things become sort of ethereal in your space. However, I had so related to that. So the school that I went to, I remember yet another sort of related event, but not identical. I'm walking past the post office on campus, and a student raises their finger in my direction as an obscene gesture. Again, something culturally that I didn't know. Okay. So then in my psychology class, it was a Monday evening psychology class, I'm sitting up front and I say to my professor, Dr. Radcliffe, what does this mean when a student does this to you? At which point my professor sort of dashes across and says, that's really an obscene gesture. What happened? So I discussed this event with my professor, and then they say, well, yeah, that's problematic. What happened? So I mentioned the student's name. 2 days later, I'm walking out of the library. This gentleman is there and says, I understand you was trying to get him in trouble. What was that about? At which point I said, well, it turns out what you did was an obscene gesture. I am at a loss as to your motivation for that. Do we have something we need to talk about? And so, you learn self-advocacy sometimes as a function of necessity is on occasion the mother of invention, so to speak. And so I had to learn certain skills that I think it would have been helpful to have some discussion with an advisor, upon embarking the trip of going into a different context, into a different culture, to say pursuit of education is one thing, but please recognize that you are going to be embedded in a certain context that's going to put demands upon you in a way that perhaps you may not have anticipated. So that's what happens.
Exactly. So I want to touch upon your education again, and you mentioned Toccoa Falls, where you went to college. So I did see that in Toccoa Falls, you majored in communications and you had a minor in Greek and apologetics, which I find interesting because I'm now curious to know, what was that transition to an interest in psychology?
Yeah, so interestingly, initially upon getting to that school, I had plans of perhaps launching into radio broadcasting at some point, entertaining, going into Zimbabwe, doing private media. In my sophomore year, it became quite apparent that the then president of Zimbabwe, Robert Mugabe, had clearly no interest in any competing media, save for the one that was state operated.
Right.
So at that point, I pivoted initially into apologetics as well as philosophy of religion, largely because my interests were perhaps to go into law school. However, I was beginning to take a few courses in psychology, and that really piqued my interest in such a way that when I graduated, I thought, well, I'm not sure if pursuit of law school is necessarily the best way in which to utilize my strengths, my interests, my curiosities. So then, after I graduated, I worked for a little bit in business, and that did not sort of scratch my itch in terms of am I serving my community the way that I would like to? And so out of a whim, actually, I consulted with Dr. Michael Penn, who is a African-American psychologist who teaches locally at Franklin Marshall University. And so we went to lunch. We had numerous conversations about grad school. I talked to two other psychologists, and the conclusion was, well, if you have this motivation, this interest, and I was also volunteering at that point at a local outpatient psychotherapy office clinic, helping them with intakes and phone calls and so forth, after work. So in those conversations, what happened is it was pretty clear from several sources that if you're going to do this, you really need to think about committing to grad school. And so you take the GRE and do what you have to. So sort of half-heartedly, I took the GREs. I did fine. And then I interviewed at a couple of schools, and then I really got offers. And so I had to think through, do I want to do this? Do I not? And sort of last minute went for interviews, and I was attracted to what Widener had to offer me, just because there was really a strong clinical emphasis, a diversity of theoretical orientation in the faculty that was interesting, and a very strong emphasis in psychological assessment, which I will also say, perhaps simplistically, there was something about being able to get pretty specific answers, for the most part, in the scientific method that was attractive to me, particularly about neuropsychology. So
yes, great. Now, Widener is in Pennsylvania. So where were you at the time when you applied?
So I was in Pennsylvania. So we, got married. My wife and I got married, and then 2 years after we got married, I was still working in banking. Actually, we had a conversation about what's the distance from where we just purchased a home as well. So Lancaster is about an hour from Philadelphia, which is where my school was. So the question is, do you commute an hour and a half each way, traffic considered, for 5 years? Do you move? And so we had to kind of navigate those things. But because of where we were, so the other part of my reality is that at that point so I was married. My wife and I, we had one child, and so it's an interesting issue, Nana, to go into grad school, not just with, well, I'm a single guy or single woman doing this, but you also have other expectations, such as family. And so it's a delicate balance, because then you have your classes that you have to attend to. You have, our daughter was born during my second year. So, you come home and you are reading, you are wrestling with your kids, you are going into the creek with your kids. And so it's having to navigate the demands of grad school while similarly holding multiple other aspects in your hands. And so there are choices that I had to think about making, like, how do you then restructure your social life? It's what you do as a person without those responsibilities is different than what you do as a person with those responsibilities. And so it's the issue of learning, prioritizing what's important, And
you ultimately think it was a benefit for you that you came to grad school with this sort of family establishment, and you already had professional experience? Because I know a lot of people who come into graduate school may have just come fresh from undergrad, and they're very new and blue, and they're kind of still looking to continue that sort of college life, whatever you want to really describe that as, but really be social and single. But do you feel like for you it was a benefit to having sort of gone past that already, and you're coming in just focused on the schooling to further your career and further your ability to continue with your family, continue? building a family?
I think so. Naturally, that's a very biased response, right? But it's it's a self-favoring bias. I think so, not simply because it was my experience, and so one of the reasons is that I'm still on faculty, albeit adjunct, for George Fox University. At one point, I was like three-quarter time for them, and so we were looking at students coming to a doctoral program, and so the students we looked at experiences of folks who had lived experiences, who had, even if it's taken 1 year to go do something different, whether they volunteered with an organization overseas, whether they worked in industry or something, it seemed to me that there is a perspective that is outside the confines of our textbooks that folks bring from their lived life experiences.
Yeah.
That said, I have seen, and I have numerous colleagues who did thrive, even having gone, directly from kindergarten all the way to their PhDs, and have done well. So I think it's fair to say, likely not one size fits all. Nonetheless, there's a richness that comes from people's life experiences that can enrich even our conversations with our instructors, our conversations with peers, illustrations to what is being discussed in didactic conversations such as lectures and so forth. So for me, I think it had its benefits. I would imagine as well, however, that my stress index was at a different threshold than that of my colleagues who had
Right.
probably less on their plates. So,
Right.
so it's a compromise of what matters, what doesn't.
That was going to be my follow-up question, because I understand the bias that, yes, for you it was great, but were there any cons to your experience in grad school that maybe you look back and you're like, oh, I kind of wish I had that experience of being fresh and new, because maybe, I'm curious, did it interfere with like your socializing with your fellow classmates or anything else that you sort of look back and like, I wish maybe this could have been a little bit better?
I have no really. My experience was, to me, a growing experience. It was a
Mhm.
helpful experience, about which I have no appreciable regrets even now. There were demands. There were certain times that I had to navigate, some challenging things. So you have I have family in Zimbabwe, and there were times where I think 3 times in grad school, in a space of about 2 years, we had to fly overseas, sometimes because there's loss of a sibling during the ravage of HIV/AIDS, and so you're gone, you come back, and you are not exactly. So there are places where certain highly driven people like myself, I had to get perspective that, well, that B plus in psychopharmacology, while it may not have represented who the student I otherwise would have been, it's more meaningful than the A I got in my neuroanatomy class, because that's also the B plus I got during the time I went to mourn the passing of my sister while as a grad student. And so, it gave me perspective about what matters in life, purely as a function of, well, I am and always will be an African, although I've lived more than half my life in North America. That's besides the point. The reality is that there is always a part of me that, so this summer, we're going to Zimbabwe. There's always a part of me that has to stay connected to those elements. And I don't think that, grad school is some kind of exile from the things that, or who I am as a person. Um, so yes, I will give you that. I didn't go to certain pubs or hangouts and restaurants with colleagues. At the same time, in retrospect, yeah, did I miss out on things that were Copernican or formative in my professional development by not being there, I am not so certain. I have rich relationships with colleagues with whom I went to grad school, decades later now. We get together, summers, we hang out, enjoy salmon or whatever people are having, and whatever beverages they're consuming. And so the relationships, if the true relationships that I had have remained largely robust subsequent to graduating and going into a professional career. So, yeah.
Well, that's good. That's a very good perspective and a very good, ultimately, a great ending to that grad career is to have that community built. That's wonderful.
Yeah.
Now, I want to touch upon maybe fast forwarding a little bit, or maybe not, but your dissertation was looking at cognitive problems in TBI patients, which I found very interesting because my sort of entryway into neuropsychology came when I was a research assistant right after college. I was working at a nonprofit brain trauma foundation. And our first study that I was on was looking at eye tracking metrics and neuropsychological functioning of athletes with TBI. And so the staff that I worked with very closely was a neuropsychologist. And she was the one who actually kind of introduced me to the field and the concept. And as a research assistant, I was helping or assisting, or I guess not even really assisting, but I was administering a lot of the neuropsychological tests for our athletes who had concussions. So doing the assessment baseline and then doing the post-injury 3 months, 6 months, 12-month time point. So that really became my foray into neuropsychology testing. And so I'm very curious for you, what inspired this interest in the TBI population for you that you made it your dissertation?
Two things that developed simultaneously during my second year is that I made connections with Paul Esslinger at Hershey Medical Center. He's at least in terms of publications, he's fairly prolific, publishing neuropsychologists related to executive functioning, frontal lobe, pathology in patients. In part because I was volunteering at a mental health facility in Lancaster, I became aware of Dr. Esslinger, and Hershey Medical Center is not too far from my home. Mm-hmm. And in that same year, my then instructor, Ken Goldberg, and colleagues had, put out a book chapter on TBI and neuropsychological profiles. And I think at that point, research was nascent, was young in its development with respect to what we understood about TBI.
Right.
We knew there were cognitive presentations in these populations. We were not so sure what we knew about the socio-emotional components involved in TBI, particularly frontal lobe mm-hmm. injuries that we can demonstrate. So I wanted to sort of look at it as new leaf, if you will, or a new component or a different component to our assessment of TBI, in part because if all we looked at was cognitive components without assessing the socio-emotional aspects, I believed we were leaving out just huge aspects of who we are as people. So as psychologists, first, I think it's important that we recognize that we're dealing with whole persons. We are not, the second cousin of a neurologist as a profession. The emotional, the affective, the socio-behavioral components are equally important. So what we were seeing at Hershey my training in assessment was developing, and I was doing some volunteer work with Esslinger at Hershey. And what we're seeing in those patients is you in many cases would have a family member, a spouse, a parent saying, she is not who she was prior to the injury, or he is not who he was. Something has changed. And yet, I look at Wisconsin card sorting measures. The data are pretty sweet. They're pretty, the cognitive neuropsych measures, nothing suggesting appreciable concern, slight changes. But I wasn't sure what we were doing with. But how are they in terms of the affective, the cognitive, the emotional, and what measures are we engaging to evaluate this? And at that point, George Spivak, one of my instructors, had developed the means ends problem solving, which he had done with populations of individuals who made impulsive social decisions, not so much cognitive, but social decisions. And so, and part of what we're looking at is these folks were struggling with, what he termed means ends problem solving. That is the distance between where things start and what a good solution looked like. Filling in the blanks between that space was very challenging for people with socio-emotional deficits, particularly in the context of brain injury. So my interest at that time occurred as a function of two key relationships for me, one with Paul Esslinger, one with Ken Goldberg, both of whom were looking at TBI populations. And I saw room as a young neuropsychologist for not just research, but maybe adding to what we bring to the quality of the lives of the folks we work with. Because for me, anyhow, assessment is not simply throwing out a bunch of data. At the end of it all, people come to see us not because they want to hear the numbers of, oh, your IQ is in the high average range, well, thanks for sharing, but what does this mean for my life and where I live and where I have to function? And so we wanted to think about how do we bring sort of, quantitative data to inform quality of life for folks whose lives have been altered and changed by an event that affected their neuroanatomy at some point.
The TBI populations that you're often working with were, assuming a little bit past the mild stage of concussions. These are people with severe injuries, right?
Severe, and these were, some of them were acquired, right? So the folks who have, who had, orbitofrontal injuries. So not to be grotesque, we had, an individual who had an accident with a chainsaw that perforated his skull and was so severe, in that instance, insult. But also, in addition to that, there was extended loss of consciousness for this person. And not just, we had, numerous patients who had severe injuries that we were working with, sort of moderate to pretty significant, TBI in those instances. And for the most part, at least at the clinic, folks were working with cog rehab, and people were not thinking about what are the affective, emotional components, and how do we even begin to address that. This is not your. I had a minor concussion playing soccer, and those were not the populations we were looking at for sure.
Right. Okay. Yeah. And when you're trying to really dig at the root of the affect and the emotional changes, what were some of the findings that you came across? I'm imagining depression might have been one thing, because there's a lot in the news about how affect and depression is prevalent in people with TBI. But what really concerned you the most in your findings as you're looking at how affect and emotions changed?
Yeah, so one of the things that was quite clear is that for some folks, there was an appreciable level of apathy. that previously would not have been descriptive of them. So you had somebody who may have been gregarious, socially curious and engaging. So there's a change, there in terms of presentation of apathy. There were instances of poor frustration tolerance that then manifested with notable anger, and occasional episodes of rageful behaviors. So these were quantifiable, statistically significant changes for these patients, but also even compared to community living peers, or all else being equal, these were pretty significant changes, even when you look at those data. And at an application level, when then you are doing conversation and communication with support systems, family members, and so forth, it gives you an appreciation for the larger impact, systemic impact of TBI, not so only for the patient, but for those with whom they are engaged, for those to whom their life should and does matter, which, at that time, I think there had been very few studies looking specifically at the sort of the affective toll of that, first for the patient, and then, for their meaningful communities, if you will.
Right. And so your methods of assessment, from what I'm gathering, involve having interviews with family and friends, community, and then also you have standardized assessment tools to capture affect. Is that what I'm? Would that be accurate?
Initially, certainly during the dissertation stages, yes. Currently, when I do assessment, so first of all, I do lifespan neuropsychology. So the things that drive, the variable that drive what I have to do in assessment, or what I get to do in assessment, can be patient specific, but it depends on the referral question. So for example, when I am doing a criminal forensic examination, I will certainly engage with the person I am, the examinee, whether I'm working for the defense or for the prosecution. I will engage with the examinee. I will engage with collaterals, family members, sometimes co-workers, sometimes previous employers, members of perhaps the victims. So let's say it's a capital murder trial or evaluation, where I will have to, talk to employers. I've had to talk to neighbors. I've had to talk to siblings to the degree that they'll engage me, then the attorney, and then the physicians that have worked. So I'm pouring through sometimes thousands of pages of records. And then there's a time at which I will engage neuropsychological assessment. And in keeping with the standard of practice, multiple performance and symptom validity indices, both independent and embedded, to make sure that we have veracity and trustworthiness of our data. And depending on the question on the table, domains that are specific for the assessment. So that can get to be extensive. When I'm doing independent medical examinations, where sometimes I can't talk to collaterals, I tend to have a lot of data that are provided for me from various medical professions. So somebody who may have had an accident. I had an individual who several years ago was deplaning, coming off a plane, going to a vacation, and somebody behind them slipped, fell, and then they impacted the tarmac. They were airlifted to another city. And so here we are 15 years later, and they still indicate they're unable to work. They're disabled. And so in the context of an independent medical examination, I'm getting thousands of medical records for this individual, what their job description was before, and the symptoms they are having currently. And then a conversation with them about what's going on. So you have to interview the person with whom you are working with an empathetic, neutral position that honors and respects the individuals with whom we work, and then let the results fall where they should and where they may. I had an instructor who said, well, at some point you're going to have to make a call. What's going on? You have to answer the question, right? That's what our work is, answering the referral question. And the referral question is not, what are the numbers? They do matter, but the numbers are just one instrument to help us answer the ultimate question and support the folks we are engaged with professionally.
Right. I'm really glad you brought that up, because I can share that when I was working in the field of neuropsychology as a research assistant, my instruction was very much administer the standardized assessments and then get out of there. And for most of my research experience in neuropsychology, working again with MTBI, I've never had that opportunity to engage in that sort of more clinician-focused interview portion of really talking to people, getting their thoughts and perspectives, talking to family members like you were talking about before. And to me, it's actually a very daunting task to think about talking to someone's family members about their injury, or talking to neighbors or siblings. And I know that comes with the training that you've received, but I'm curious for you, what was that like, getting out of just, I'm not just administering these standardized assessments and being very methodical, but now I have to actually talk to people and hear possibly some very painful stories, some very harrowing experiences, especially when we were talking about that forensic neuropsychology consultation. Was that a difficult thing for you to adapt to, or can you also talk about a particular instance where that was a very hard experience interviewing someone, where maybe it got very personal and perhaps even uncomfortable for you?
I think whether it's in assessment or in psychotherapy, right? I think we all get to and have to work on the old psychoanalytic concept of transference and countertransference. Mm-hmm. So Nana, I would want to claim that I can work with every patient who walks through my door, and that would be patently false, right? Because there are some people for whom I am not likely a good therapist for them. And, to my earlier conversation about being in college, my guess is that I would likely not be a good candidate to provide therapy to somebody who comes in saying, well, I'm part of a hate group and I want you to strengthen my skills in functioning in that capacity. I probably will have to disqualify myself, right? And that's an extreme example. But the point is, we have to realize that we are human and kind of own that, and also know that there are some instances when we may or may not be effective, our training notwithstanding. But that said, I think sometimes we hear. So I'll give you two examples. I had a grad student, actually a postdoc. He and I were interviewing a woman that my student, he's in for the, I think, second meeting that we're having together. And in that second meeting, I said, well, we're going to meet a patient who grew up in this country, in the US, then their family moved overseas and they were doing religious ministry missions work. And so I said to him, well, you should read the chart and then we will interview the patient in a clinical setting. And then, after that, we'll kind of work through how we want to structure our assessment. So what we do, in private practice is we'll see the patient. Sometimes we'll do the testing the same day or couple of days later, depending on how busy our schedules are, and then we'll do feedback. So there are really 3 encounters at most, 2 under other circumstances, So the person comes in, And we had looked at their written information before, and there were things not in that information. Then they described a rather horrific experience where this woman was just abused by many people at one event in the home of a field religious leader for their organization. And she's in tears, and we're sitting there, and so you have to work at being a safe holding environment containing just the horrific trauma the person went through, and at the same time communicating a sense of hope for them, and being able to empathize with them in the moment as a compassionate person. And after we're done, we scheduled for the person to come back. We gave them some time after we were done with the intake, just for things to sort of turn down the temperature of where things had gone as they were sharing their very difficult, horrific story. After they exited the room, my postdoc is wiping tears from his eyes, and I said, "No, wait, let's talk about this. Is a pretty difficult one, right?" And he said, "Yeah, sometimes I wonder if I'm cut out for this work. This is just too much to bear, right?" It's true. It stirred something up, and it'll be callous and foolish to say, "Well, so get your therapy," but to sit there together and kind of work through that with tenderness, with care, with compassion, and make sense of that, and say, what. So I said, don't ever lose that sense of being human and connecting with people. It at the end should not overwhelm you, but it's good that you have that. Because it gives you capacity to connect, and at some point it should strengthen your resources to be there with those folks. In a clinic, in a forensic context, it's I'll tell you, I not too long ago was sitting with somebody in an evaluation room at a correctional facility as I'm doing my interview with this individual before I started administering neuropsychological measures. And so, there are people in chains walking by the room, clanging outside, just, different context. And, to sit there with a person who is in that position because someone's life ended at their doing, and there is no sense of remorse or regret about what happened for them. It's always a tricky thing to sit with that, and then the larger context of you're going through your records, particularly the legal records that include perhaps images of the now late significant other who lost their life at the hands of someone you're evaluating. It's there's no way to be in that space and not recognize that this is a tough situation, and it's not just a case, it's not just a forensic evaluation, it's a person whose life has been altered, and whose decisions and behaviors, and in some cases choices, have now put them in a very awkward position. And yet we have to have a conversation about the context, the motivations, their experiences, their upbringing, and assess now how their brain is functioning in the domains of interest, pursuant to trying to get a sense of what's going on, so that the legal system can render them the most just process toward their presenting challenges. So,
Do you feel like, more of a general thing, and maybe, I think that I want to frame this more as a general question for you. Do you feel like any amount of academic training, graduate training, can really prepare someone for approaching a situation like that? Or do you feel like it's just a matter of kind of, in a way, just going through the fire and just going through the experiences? Do you feel like that's what really kind of molds you? Do you feel like you really can ever be fully equipped by academic training to handle, talking to someone like who you spoke to, who has done something so reprehensible, and trying to sort of contain yourself and contain your emotions and maintain that affect to do your job? Or do you feel, again, like it's something that you just learn through going through it again? Or alternatively, do you feel like, I know we haven't touched on this too much, but maybe drawing from another source like your faith, or it sort of helps you, sort of guide you through those challenging situations?
Well, to the question of can graduate school train us for that? It should. Does it? I don't know. I think there are many things that grad school should prepare us for that it may or may not. So for example, I own a practice with now currently 23 individuals on our team. I did not have a business course on how to run a practice. Grad schools don't teach us how to do contracts with insurance companies. They don't teach us those things. Should they? Yes, I think so. And so I saw in that instance, I had to borrow from my experiences in business to how do I use those experiences to inform contract negotiation, not just with insurance companies, but with attorneys and things like that, right? At the same time, I think for most people, yes, there are numerous resources, including faith, including friends, including community, but we should get training, I think, in the work that we do, and so to me, the training that we get working with all kind of patient populations, right? I mean, whether you're working with a sort of malignant narcissist who thinks only about themselves, and they come into therapy, if you're doing therapy, and they devalue you one moment and the next moment they exalt you like you are a wonderful person, and then they chop you down, and or the person with borderline personality presentation. So we deal with people in small degrees with just varied personality presentations. I think at some point, good training, good supervision, good reading, at least should give us enough skill sets to work with the average person. So there are several individuals in the sort of forensic judicial system, correctional institutions, who are not perhaps violent people that we should have good training in working with those populations. But even in instance where you are dealing with folks who may have engaged in significant challenging behaviors, when we enter the assessment process, my guess is our experiences help us with that, but supervision helps us with that. Consultation helps us with that. I mean, I had an attorney reach out to me saying, "Can you evaluate this now 25-year-old person who at 16 tied up his adoptive parents and ended their lives in a gruesome manner that was in our local newspaper?" And so they asked, "Can you go and evaluate this person? Supposedly they found faith in incarceration." They may not have. That's not the issue. And really, what they did is, we have to trust the justice system to do what they have to do. But I have to, if I want to engage this process, I have to think about, can I be helpful to this individual and their party, their attorney? That is, I'm not doing an assessment for the benefit of the attorney or the individual per se, but to get data that can assist the decision-making process, the trier of fact, whether it's a judge or a jury, to say, well, at least neuropsychologically, here are the key pieces that have to help us think about what we do with what we have to do. Because at the end of it all, whether it's a capacity determination or it's a retired NFL player I'm evaluating for purported, concussive presentations, the decision of what's done with that person is not exactly in my hands. At the same time, I have to present the fairest, clearest information to the question being asked, so that the person, whether it's the player, whether it's this incarcerated individual who's got to go through a trial about sentencing. Those decisions are for the judicial system or for the IME company, but my task is to make sure I do the best job in describing where the person is. And so to your question, can anything prepare us to deal with what can be challenging, gruesome, difficult, harsh situations? Yes, our training should help us with that. Our own therapies at some point, our own community resources should help us. I think, before we will talk about you should successfully find ways to compartmentalize. Is that realistic? I don't know. I just think you have to find a way to integrate things into who you are, and also be able to make separations between what has an impact on me immediately versus what churns my own empathy and compassion. Those are two different conversations, I think.
That makes a lot of sense. And that's a heavy crown to wear, to have
Yeah.
to consider all of that, for sure. And
so there's the planning time, Nana. Like, to me, first of all, you have to answer the question, do I not want to take this case?
right.
So when an attorney calls me and says, well, there's a triple murder homicide in a drug raid, and the person claims that they had a brain injury when they were 2 years old now. So I have to decide, do I want to take this or not? And second of all, if I take this, am I able to maintain my objectivity in the process? And so this also helps us decide, what I say yes to and what I say no to, and what I say yes to or no to should not be driven by what's the economic benefit to me for that. It is, am I the best qualified person to help this individual answer that question? The economics can take care of themselves in a different context. That's a different conversation. So,
definitely. And I know you're sort of putting this under the umbrella of your current practice, where you're the clinical director of Providence Behavioral Health Services. And I wish we had been able to talk more about that, because I'm very curious about just you mentioning, having to have all this business acumen in order to even be in a position to own your own practice. But one thing I'm curious about is, in your position, which you really earn with your hard work and your years of training and everything, for you, I guess, to parse it, what is the hardest thing about being in the position of a director of your own private practice? And what, in addition to the hardest thing, what do you love the most about it?
The most challenging aspect about being director of a practice is that, try as you may, you can't guarantee consistent efficiency and quality of excellent service delivery. That is, the way I may do my evaluations and my reports, or the way I might approach psychotherapy, if I were a therapist, is likely different than some of my colleagues that work in our practice. And the way about which I may go about, documentation of the work I do in therapy may be different than the way other people go about documenting their work. And so I think the challenge then of directing a practice is that, by choice or not, you wind up being responsible for decisions people under your supervision, if you will, or under your management, if you will. The decisions that they make ultimately reflect on you. There is no running away from that. And therefore, you better do a tremendous job of making sure that hopefully you hire well, or you train well, and but you also have to stay on top of certain things that may not be attractive to you. So transparently, I'm not, like currently we're having conversation with an insurer who has an issue with our charting state describing the folks we work with as either patients or clients, because in their mind it's hierarchical language. And honestly, my patience for sort of bean counting foolish things that have no merit towards evidence-based interventions is it's challenging,
Right.
and so you wind up you as you said, sometimes heavy is the head that wears the crown. Sometimes you have to deal with certain things that are not exactly things you think you signed up for by saying, well, I want to help patients, right? I want to help
Right.
folks in the community. So there is that. That's a challenge. It's an opportunity that you sort of have to grow into. I mean, I think all of us went to grad school, hopefully to educate, to supervise, to work with patients, and not so much to do administrative stuff, but it's comes with the
Some of
dinner.
the territory.
Yeah. The so that's that. But I think to me what is satisfying is to be in this space that we are. I think as psychologists, certainly as neuropsychologists, we get to have conversations with folks, whether patients or colleagues, providers, about an interesting component of brain, which is not just, okay, so what do the MRIs look like, or what did the PET scan data look like, but what can Jane Doe do in her business as logistics manager now that she has these memory deficits secondary to diagnosis of MS, so to be in a place where our work and our understanding of brain behavior relationships can inform and support folks functioning in their life is, to me, is very fulfilling. Or when I'm sitting there with parents of a 12-year-old who has bona fide dyslexia that has been missed and who has been prescribed, vision therapy, which has no research support behind it, and several things that they've tried and come up empty, and to say, well, here's where the literature is, and this is what we're going to do in terms of addressing these challenges, whether we are doing some Orton Gillingham intervention to navigate the reading challenges of the child. Just to be able to provide, again, Nana, people come to us not because they want our numbers. They want actually solutions for, we are having this issue. Can we see some movement? Can we see some improvement? Can we see some growth? And to be able to speak to that and provide folks with, here's how we can go about doing that. So one of the, really fulfilling things that happens, a couple of weeks ago, I got a call from the mom of a now 23-year-old individual that I evaluated about 5 years ago. And so at feedback, we talked about, advocacy for, their child with autism in a certain context. And the mom actually left me a voicemail saying, and the mom is a, behavioral health worker. And the mom left me a message saying, thanks for working with XYZ 5 years ago. Given your feedback with us, we've now started a nonprofit foundation educating folks about ASD, autism spectrum disorder, and how it may affect young adults. So you look back, Nana, and you say, well, for all the frustrations that we all deal with, you hear this story and you say, well, perhaps what we do has greater value than sometimes we see in the moment.
And it does.
Yeah,
it definitely does. That's great. Wow, that's a great sort of thing to take away from what you do. I really love that. Thank you for sharing.
absolutely.
And I want to end this on something you said earlier, because it's staying with me as we've been having this great conversation, which is, you said earlier that for how many years you've been in the US, you're African. And that's something that I really want to sort of bring to the forefront of our spotlight feature. That's the theme, of course.
Sure.
And so for you, in terms of, obviously, that you're based here in the US and you have a practice here, what does it mean to use what you've amassed here and your training here when it comes to giving back to Zimbabwe, or really sort of making sure that all the work you're doing to provide resources to people can also filter into where you've come from? Is that something that you've had conversations about, or you think about, or you're even currently trying to implement in your life?
Mm-hmm. Yeah, so I think opportunities come our way in numerous ways. So, for example, my good colleague Ted Judd, who I think you know, Dr.
Yes.
Judd, and he's just an amazing individual. So he has been teaching a neuropsychology course at the University of Zimbabwe, and so he would do this every so often. And I had a chance just this past summer with a couple of colleagues to team teach with him just one lecture where I had to present on a neuropsych case of my choosing, and just knowing the severity of vascular risk factors in Zimbabwe, and a good chunk of the population. I presented a case on vascular cognitive impairment to students at the University of Zimbabwe with the support of Ted Judd, and so there have been relationships that have developed from those contexts. For example, I had an opportunity at the invitation of Dr. Farzin Irani, a colleague of mine as well, locally, who did a text on neuropsychological assessment in international context. And so I had a chance to edit a book chapter about assessment in the context of northwestern parts of the continent, particularly Nigeria, and give some feedback to the chapter author just about some things they would have wanted to think about in putting the chapter together. And now that the book is out, it's a way of supporting colleagues, and they're informal context. So there are people who do psychotherapy or trying, like I'm meeting next week, 2 weeks from now, for coffee with somebody who wants to brainstorm about how do you do mental health services in Southern Africa, particularly if you don't have formal training. That is, you don't have a master's degree, never mind a doctorate degree in any kind of mental health field. It's small steps. When I go to Zimbabwe, there are times when I've gone to like rehab facilities just to see what kind of work is being done there, and you come away sometimes seeing sort of the riches of the West in terms of resources for just the kinds of things we can assess in neuropsychological assessment, and how we can do a lot better. So now there's a battery for African neuropsychological examinations you can do. And it's a stab, right? The continent is a bit more complex with 50 some countries, but you got to start somewhere. So yeah, this is an intrigue. It's an area of interest, and I have physician colleagues who do work with kids with malaria that we will talk about. How do we think about cognitive functioning, and so yeah, there's more that can be done. I will tell you, I certainly am not anywhere near satisfied with my level of engagement or investment in that. I have recently explored joining the South African Neuropsychological Society just so I can keep myself involved with what's happening, if for nothing else, to support colleagues who are doing work on the continent.
So thank you so much for sharing that.
Oh.
And Dr. Chakara, thank you so much for your time today. I really appreciate it. This was a great conversation for me. I learned really a lot about just what it takes to do what you do. So thank you so much for sharing your wisdom and your insight. I really appreciate it.
Well, it is a pleasure. And, I will say, to the degree I can support colleagues, even just, in this association, whether it's navigating through aspects of a dissertation or just consulting on a case, my information is available. So hopefully that happens.
Definitely. We'll definitely get that information out. Thank you so much, Dr. Chakara. Really appreciate
your
time.
Enjoy your weekend.
Take care.